Well, good morning, everybody. Welcome to Grand Rounds. Hard to believe that it's spring 2022, and we're very lucky to have a vision of the future of urology with our three chief residents giving their talk. This is a culmination of many years of clinical practice and having their research year, so we're really looking forward to it. I also see that with the tele conferencing, I see Jim Paleshi and some other folks that don't have to drive all the way down to San Francisco can join us. So thank you for everybody from afar who's also joining us. So we'll do it in a format where we're going to have John Lindsay, Maya Overland, and then Heiko Yang talk. They'll be talking for 15 minutes, then we'll have 5 minutes for discussion for each person. So we're very excited about this, and we'll start with Dr. Lindsay. John, you're on board.
Okay. Thank you, Dr. Stoller. Let me share my screen here. Okay. Hopefully everyone can see that there.
There you go.
Okay, and then let me minimize all of you. All right, so good morning, everyone. I am honored to have this time to talk about my year as a Biodesign Innovation Fellow. Stay tuned for my journey talk in about 30 years. So many of you are familiar with Biodesign. It was founded about 20 years ago by interventional cardiologist Paul Yock, who began his faculty career at UCSF, and Josh Macauer. The goal of the program is to provide the knowledge, skills, mentoring, and networking required to deliver meaningful and valuable innovations to patients. I first learned about biodesign when I was interviewing for residency, and I ultimately decided to do this fellowship because it aligns with my career goal of integrating my engineering and clinical training to empower patients. Many companies have started from biodesign. iRhythm is the company that created XyloPatch, which many of us order for patients with abnormal heart rhythms. UroLift is not a direct product of biodesign, but it is the creation of new biodesign director Josh Macauer, and many of us are familiar with this product as well. And then finally, ZenFlow is one of the younger companies from the 2011 class, which props open the prostatic urethra. And just in the past years, secured Series B funding and begun its pivotal clinical trial. So we may soon see this one in clinic. So each year, Biodesign accepts about 10 to 12 fellows. Roughly half are engineers and half are clinicians. Each year, a clinical focus is chosen and announced at the start of the fellowship. Fortunately for me, this year's focus was nephrology and urology. My team of 5 included Sarah, a biomedical engineer from the UK who works for the NHS and has a background in biomaterials. Susanna, a biomedical engineer from Portugal, who has worked extensively in the heart valve space. Ranjith, who just completed his residency in neurosurgery, and also has his own startup. And Ashwin, a medical student from Penn, who had a startup as well prior to med school that was funded by Y Combinator. So I learned so much from each of them over the year. Our primary task as a team was to master the framework that you see here, which is Biodesign's process for medical technology innovation. There are 3 phases: identify, invent, and implement, with a particular emphasis on the identification phase. Within each of these phases are smaller stages that offer a reliable approach to innovating in the medtech space. So to quickly get us up to speed on this framework, we began with a 4-week boot camp. Each team was given a clinical vignette and was tasked with identifying unmet clinical needs. In this short time, we went through the entire process from the unmet need to ideation to concept development. The foundation of this process is the need statement, an example of which you can see here, which is a one-liner consisting of a problem, population, and an outcome. In parallel, we received 90+ Zoom hours and lectures from faculty in the nephrology and urology departments to get everyone up to speed in these topical areas. It was pretty fun to watch my teammates become urologists over the year. So after boot camp, we were launched into our clinical immersion, observing nephrologists and urologists in various practice settings. We recorded over 800 observations in nephrology and urology and converted these observations into need statements. Utilizing filters that were priorities for our team, such as the impact on the patient or healthcare system, or the level of understanding of the disease mechanism. We progressively filtered our needs until we arrived at our top 2, which you can see here before you. So both fall under the umbrella of sexual health and both focus on improving patients' quality of life. The first need was an erectile dysfunction, which might seem well addressed on the surface, but through the biodesign process, we realized that there's still a significant opportunity to improve patients' quality of life. Our second focus area was in pelvic organ prolapse. The importance of this need cannot be overstated, given the severe impact it has on women's quality of life. I'll begin by discussing our focus in erectile dysfunction. So with ED, we identified a population with a clear unmet need and a simple solution. We also uncovered several commercialization challenges, and I'll quickly discuss some of them. This audience knows ED very well. It's a problem affecting 30 million men in the US. As we know, initial treatment typically involves oral medication, but about 10% or 3 million men are either refractory or cannot tolerate PDE5 inhibitors. So for the remaining solutions for this population have numerous shortcomings. They're either ineffective or painful to use. Alternatively, a patient can opt for a penile implant, which requires invasive and irreversible surgery, which leaves us with ICI, and probably the most commonly used treatment for ED refractory oral medication. Has an estimated market value of 450 million, and is the most efficacious of the non-surgical options with up to 90% efficacy. However, this treatment also comes with a high dropout rate. So to better understand why, we spoke with numerous ICI users from around the country. We mapped out the user journey through in-depth interviews with patients. They described to us the constant anxiety of having to inject their penis. Patients first leave their partner to go to the fridge, get a syringe, draw the medication from the vial, check the correct dosage was drawn, return the vial to the fridge, clean the injection area, and holding pressure after injecting for 2 to 3 minutes and waiting another 5 to 15 minutes for activation. So it's a very cumbersome process. And then another major barrier for men that we interviewed was having to first learn this uncomfortable process in a comfortable clinical setting. So our surveys revealed that patients were frustrated and dropout rates were as high as 70%. So with most of the patients dropping out within the first 2 to 3 months. So these figures were validated with local pharmacists. Reasons for discontinuation were varied, with 1/3 of men dropping out due to pain associated with injection, another third due to the inconvenience of administration, and many more dropping out due to the psychological barriers of self-injection. So we identified an opportunity to transform the patient experience. We designed a novel injection device that solves key patient-identified pain points. Importantly, our concept uses the same mechanism of drug delivery as current ICI, so a pretty high clinical efficacy. So our device simplified the process for the patient using pre-filled customized drug vials and allowing patients to preset their desired dose. The simple design also requires minimal dexterity to use. Throughout the process, the needle is never seen by the patient, reducing the psychological barriers associated with injecting. Pain alleviating vibration technology also ensures that needle deployment is unnoticed. Finally, we were working on a user interface to allow for perhaps an initial appointment in the privacy of the patient's home and improved drug titration. So we built some work slide prototypes seen here to test a variety of needle deployment mechanisms. The setup on the right shows testing of different vibration parameters to optimize for pain alleviation. And we also filed a provisional patent for this design. So what's next for the solution, and what does the road to commercialization look like? We know that the technical development risk and clinical risk of the project is low. Instead, the main risk focused around market adoption. So our team, therefore, spent a lot of time exploring a variety of business models. We spoke with interested compounding pharmacy partners, and additionally, we considered direct-to-consumer models. After exploring the regulatory route in detail with industry experts, we found that our device required a drug device approval pathway. And for the targeted ICI population with a total addressable market of only 450 million, this led to a market funding mismatch, and is ultimately the reason that our team decided not to take this project forward as a startup. We do, however, believe that this technology could be applied more broadly to the larger oral refractory market with a pretty large TAM. So it's possible that teaming up with a large pharmaceutical company might prove to be a more viable pathway forward. And so while ED, sorry, has a diverse set of solutions, pelvic organ prolapse or POP is truly a massive unmet need. So most of us in the audience here know POP very well. There are three main categories, which can occur individually or in combination. They are all the result of the common final pathway of weakened pelvic floor muscles and ligaments. The pelvic floor weakens over time for numerous reasons, but all because of insults to the strength of the pelvic connective tissue. Age-related degeneration, vaginal childbirth, as well as the hormonal changes of menopause all drive this weakening. More recent research also suggests that there's genetic predisposition and obesity that may be contributing to POP as well. So while POP is multifactorial, most, if not all, experience the same primary symptom, known as vaginal bulge, described as constant pressure or discomfort, likely continuously sitting on a golf ball. Because of this debilitating sensation, women have a markedly decreased quality of life. They are unable to partake in the same physical activities that they normally enjoy. They're limited in their daily engagements with family and friends. And over time, these feelings have an insidious mental burden over these patients. Patients with POP have a 3x higher risk of depression, and there are over 5 million women in the US suffering from POP. So beyond the devastating impact that this has at the individual level, we're spending about $3 billion a year on this state. So patients who have vaginal bulge symptoms and present to care have two options: conservative measures or invasive surgery. Many go the conservative route, where physical therapies and pessaries are the mainstay. Pessaries mechanically reduce prolapse. The problem with pessaries is that they are uncomfortable and don't always solve patients' bulge symptoms. In the instances where they do, they can cause further symptoms, get infected, and preclude physical activities, which basically leaves them right back at the same bulge symptoms that they sought treatment for. And this leads to about a 50% yearly dropout rate. Surgery, on the other side, mainly suffers from the problem of recurrence, so anywhere from 10 to 40% recurrence at 5 years. So to better understand this patient need, we reached out to those suffering with POP. We sent 5 different surveys across different modalities, and we were amazed to receive over 1,200 responses from around the world. Patients poured in stories of their daily challenges with POP, and one patient summed up a prevailing sentiment saying, "I just want a solution that solves my problem and doesn't require me to come back to the doctor in a couple of years." And this corroborated with the analysis we ran on the data that we gathered, where we concluded that recurrence is the #1 reason women do not pursue surgery. So we crafted our need statement on the principal concept of recurrence, a durable way to treat women with symptomatic pelvic organ prolapse in order to reduce the recurrence rate. While investigating this need, we examined the treatment landscape to understand the opportunity better. When we evaluated invasiveness against efficacy, conservative measures and surgeries were on opposite sides of the spectrum. Even more, we saw the innovations in the space were really incremental, such as making pessaries more customized or optimizing surgical procedures. But no one was truly addressing the large solution gap that patients truly want. We found that there's a need for a solution that is more permanent than a pessary and less invasive than reconstructive surgery. So through our deep dives in Google Scholar and brainstorms, we were able to uncover a compelling insight and crafted a solution that addresses the major pain points we identified in our market research. So this is the first kind of case study we encountered. And this was a report of a neglected pessary that had been left in place for about 10 years. The treating physicians commented that in that time, a new layer of tissue had formed around the pessary, creating a structural layer of support. Most importantly, when they removed the pessary, they noted that the patient's prolapse and symptoms had resolved. Effectively, their prolapse had been cured. I was initially very skeptical of this, but the engineers in the group were thrilled. But we were encouraged after finding other reports with similar findings. We also spoke with physicians who validated this finding. Many could recall 1 or 2 patients a year where pessaries were left in place for a longer period of time, which sometimes transiently resolved patients' prolapse and associated symptoms. So we sought to create a structural tissue response in a minimally invasive way. So the device consists of a structure that provides mechanical support and easy deployment of a pessary with a drug-eluting bioabsorbable polymer that simulates formation of a new tissue layer to prevent the descent of pelvic organs. The advantage of the device is that it's no more invasive than pessary and performable in clinic. So it was important for us that there be a clear integration into the care pathway for providers and patients. The deployment of our solution is pretty simple. Patient would be fitted for comfort. The device with the polymer would then be placed, and over a period of 3 to 6 months, the tissue would form while the polymer layer degrades. After this period, the pessary would be removed. And then with this solution in mind, our next step was to further validate our market research and get a sense of whether patients would actually try a device like this. And the overwhelming response was yes. 90% of patients surveyed indicated that they would try this intervention, and perhaps more telling, 50% were willing to pay $2K out of pocket, which informed our estimation of the market opportunity. So we estimated that we would potentially be able to reach 4.5 of the 5.5 million women suffering from POP. And at $2K per patient, that would be about a $9 billion addressable market. It's a large market where our solution uniquely can pull from both the operative populations and those who prefer non-operative measures. So funneling that market down, we arrived at a beachhead of about 384 million. Supplanting or serving as an adjunct to the existing operative market. So in sort of outlining the key risks for this project, we identify the scientific risk as the primary risk. Our plan to de-risk the project involved bench and computational testing to characterize the degradation properties of the polymer, potentially in vivo animal studies to characterize the tissue properties. And then on the IP front, we're proud to have filed a provisional patent on the technology, and the ongoing patentability and freedom to operate analyses were pretty favorable. On the regulatory side, this product would pursue a PMA pathway, and we would engage early with the FDA to determine the key endpoints for approval. We also work with agency and payers on the appropriate post-marketing surveillance required for reimbursement and launch. We modeled the development pathway to bring the solution to market from preclinical validation, in human trials, all the way to commercial launch. The ensuing capital requirements are especially high for the preclinical proof of concept and expected large-scale pivotal trials. So ultimately, the project for this venture was a very highly front-loaded risk profile versus ED, which was a easy kind of low-risk profile, where high scientific risk is paired with large upfront capital requirements. Given this novel mechanism and limited evidence characterizing it in the literature, our initial estimation was that this would require further validation bench side before being launched on a commercial pathway. However, after our final presentation, we were approached by a large medtech firm who offered to fund our project if we wanted to move forward. But ultimately, as a group, our excitement for this need did not align with the likely 10+ year journey that this project would require. So with that, I'll conclude, but I just want to say thank you to Dr. Carroll, the R5 committee, and the incredible department for our invaluable 5th year. A special thank you to Dr. Stoller, Green, and Odisho, who wrote my letters for the biodesign program. And equally special thank you to all the faculty, especially MVK on pelvic organ prolapse, who offered their precious time to meet with my group as we explored these clinical areas within urology. And finally, thank you to all the residents who have inspired me and been my family over the past 6 years. Thank you.
Well, John, that was a very impressive journey that you've talked about, and that process I think will be very helpful as you move forward. I think we're a little low on time right now, and we'll move on, and maybe we'll take questions at the end depending upon how the time is, if that's okay with you.
Sounds good.
Okay.
Sounds good.
So next on board is Maya Overland, who's going to talk about her year that has come to a conclusion in this last July.
Good morning. Thank you, everyone. I'm grateful to have this moment to reflect on the broad range of research opportunities I've had the fortune to find here at UCSF. I spent a year in Dr. Baskin's lab as a medical student after finishing a PhD in fundamental molecular neuroscience that was centered entirely at the bench. I had heard of bench to bedside research, but what I was most excited about was how Dr. Baskin would start with a very practical clinical anatomic observation or question and use it to frame fundamental embryologic studies in the lab, whose findings he then took back to guide his clinical and surgical practice. In continuation of a project that I started with Dr. Baskin as a medical student, I've been working on a single-cell RNA sequencing approach to understand the mechanism of tubular urethral formation in the developing male fetus. We have extensively described the developing anatomy of the fetal genital tubercle, starting at the indifferent stage, progressing to urethral plate canalization in both the male and the female, that we termed the opening zipper, followed by androgen-dependent tubularization of the male urethra in a fusion process that we then called the closing zipper. Failure of the closing zipper leads to hypospadias. Using electron microscopy, standard histology, and whole mount 3D immunofluorescence imaging, we have shown this fusion process to be a complex one involving fusion of multiple cell layers. The fusion process starts proximally and progresses distally and can be arrested at multiple phases in development, resulting in the wide spectrum of hypospadias phenotypes that we see clinically. We realized that we could take advantage of the proximal to distal developmental gradient within a single specimen to suss out the molecular pathways at play here. In collaboration with the Darmanis group at the Chan Zuckerberg Biohub, we developed a protocol for single-cell RNA sequencing from flash frozen human fetal specimens and sequenced 8 age-matched male and female genital tubercles. Working with a bioinformatics group in Bangalore, India, we were able to identify the expected cell types within each using standard clustering analysis and to compare the cell populations across sexes and ages. We're now in the process of applying single-cell lineage mapping algorithms to this data to identify the sequential variation in gene expression pathways along a developmental trajectory. By using known markers of the involved cell types, we hope to be able to anchor our analysis spatially and to thereby identify the changing molecular pathways expressed as urethral fusion progresses. In future work, newly established spatial transcriptomics techniques that allow for targeted expression mapping and histologic slices may be helpful to confirm the spatiotemporal localization of the pathways identified. The lab has recently pivoted to studying early gonadal development and differentiation. In addition to the fundamental developmental importance of this question, there is significant immediate clinical application. When a gonad of unclear etiology in a patient with a disorder of sexual differentiation is biopsied or excised and sent to pathology, their findings often guide our diagnosis and medical and surgical management, as well as early family decisions around the gender of rearing. However, the immunohistochemical and morphologic markers used by our pathologists are by no means definitive and oftentimes rely upon a very subjective judgment call. He presented his work at Grand Rounds last year, characterizing early human testicular development. I've been working on a complementary detailed immunohistochemical and morphologic mapping of fetal and pediatric ovarian development. While the characteristic organization of granulosa cells around developing follicles is pathognomonic for ovarian tissue, we also found large swaths of stromal tissue without follicles present in normal developing ovaries, as is also often the case in poorly differentiated gonadal tissue from patients with disorders of sexual differentiation. We have characterized the expression patterns of known standard stromal markers in the developing ovary, but their expression is sparse, and the differences between testicular and ovarian stromal expression patterns are subtle. Our work underscores the need for better molecular, morphologic, and genetic markers to define ovarian versus testicular tissue in complex pathologic specimens. In addition to the clinical applications discussed, these definitions are also needed as we study ovotesticular syndrome in a xenograft model in the lab. By grafting together human fetal ovarian and testicular tissue under the renal capsule of an athymic mouse, we have created a novel human tissue model in which to study the early development of this rare syndrome. In a clinical project with Dr. Baskin, we questioned the necessity of a routine MAG3 renogram study as part of the workup for all pediatric patients with ureteropelvic junction obstruction, as these studies are more expensive and invasive than a standard renal bladder ultrasound. Using an imaging data set put together by our former fellow Erin Liao in collaboration with Andrew Phelps from pediatric radiology, who's now at OHSU, we began to explore the ability of ultrasound to predict MAG3 findings in pediatric patients with ureteropelvic junction type hydronephrosis. After multiple practice runs to confirm good inter-rater reliability, Dr. Baskin, Amy Schoen, and myself measured the renal lengths and parenchymal areas on ultrasounds from 113 patients with unilateral UPJ type hydronephrosis. We were blinded to the MAG3 findings as we did this. We randomly sampled 75% of the studies as a training set and set aside the rest as a test set. We then applied a recursive partitioning algorithm to the training set that suggested the very simple model that an ipsilateral to contralateral parenchyma ratio area of 0.6 or less could predict a split function of less than 40%. This intuitively makes sense, as an atrophic kidney would have a lower area ratio as normalized for age to the contralateral kidney, and any compensatory contralateral renal hypertrophy would exaggerate this. As applied to our internal test set of 29 patients, this simple threshold predicted a split function of less than 40% with a sensitivity of 75%, specificity of 95%, and a negative predictive value of 0.91 with an area under the curve of 0.88. Overall, a great predictive test. Practically speaking, this means that applying the threshold to our test set of 29 patients would have saved 19 unnecessary MAG3 scans and only missed 2 patients with a split function of less than 40, and would have missed no patients with a split function of less than 30%. Also important to note is that the suggested threshold of 0.6 is arbitrary, and so a more conservative practitioner could choose a higher threshold that would result in more unnecessary MAG3 scans, but fewer missed patients, and vice versa. To test it, we then applied our model to an independent test set of 88 patients from Dr. Kogan's group at Albany, with most ultrasounds measured by a research technician there. The area threshold of 0.6 predicted split function of less than 40% with a low sensitivity, but with a specificity of 100% and a negative predictive value of 0.82% or 0.82. While the model still performed well, a few more low function patients in this data set were missed, and there was overall a less linear correlation between the area ratio and split function. We are currently working to identify whether the discrepancy in the performance on the outside test set was due to differences in measurement technique or due to some fundamental difference between the data set. Continuing the theme of minimizing unnecessary imaging studies, and work with Dr. Kopp, we questioned the utility of performing a routine renal bladder ultrasound in all patients with first febrile UTI. Despite the now ubiquitous availability of prenatal screening ultrasounds with increasing early detection of congenital hydronephrosis, the 2011 AAP guideline on febrile UTI recommends an ultrasound for all pediatric patients 2 to 24 months of age after first febrile UTI, regardless of the findings of second trimester ultrasound. We already know that renal bladder ultrasound is poorly predictive of reflux, which is the most common actionable finding after febrile UTI, and we question the utility of ultrasounds for all. In a project initiated by Katie Trandom while she was a fellow here, we performed a systematic review of the literature since 1995, looking for studies that provided the results of both pre and post febrile UTI ultrasounds in pediatric patients. The majority of studies excluded patients with a positive prenatal ultrasound, and so we focused our analysis on the negative predictive value of a normal postnatal ultrasound. 8 studies met criteria with a pooled population of 2,900 children with first febrile UTI. Meta-analysis demonstrated a negative predictive value of 77%, meaning that 23% of patients with a negative prenatal ultrasound would be found to have some abnormality on a post-UTI ultrasound. However, there was significant heterogeneity between studies in terms of how participants were selected, in terms of the definition of febrile UTI, the timing of pre and postnatal ultrasounds, and in what was even considered an abnormal ultrasound finding. 3 of the studies distinguished between mild and severe abnormalities, although each used their own slightly different threshold. And a 4th study included enough detailed findings that we were able to apply a threshold to it. As expected, a meta-analysis of these 4 thresholded studies showed a much higher summary predictive value of a negative predictive value of 93%, indicating that only 7% of patients with a negative prenatal ultrasound would have significant abnormality found on post-UTI ultrasound. However, there remains significant heterogeneity and study design bias even in the subgroup. Based on our review, we concluded that the AAP guideline is justified based on the current evidence available, but our sub-analysis suggests that cleaner studies with more clinically relevant definitions of abnormal postnatal ultrasound could change this. So, to address this gap, we have carefully designed a large retrospective study in which we are reviewing all renal bladder ultrasounds performed in pediatric patients under age 2 over a 10-year interval at UCSF. From chart review, we then identified those studies that were performed after a true culture positive first febrile UTI. With hard work from our awesome team of medical students and residents, we have reviewed nearly 800 charts, 205 of whom had a culture confirmed UTI, and 58 of whom meet all inclusion criteria with prenatal and post UTI sonograms available for review. Our collaborators, Dr. Gonzalez from fetal medicine and Dr. Duran from pediatric radiology, are doing a structured overread of all prenatal and postnatal ultrasounds for these selected patients. And we will use this to calculate the true positive and negative predictive values of prenatal ultrasound for findings on renal bladder ultrasound in pediatric patients with first febrile UTI. We are hopeful that our findings will help guide a practice change or at minimum confirm the evidence behind the current guideline. With Dr. Kopp, we also just published our experience piloting awake bladder Botox in pediatric patients with neurogenic bladder. Cystoscopic injection of Botox is typically performed under general anesthesia in pediatric patients, accumulating repeat anesthetic exposures and OR costs. Because of this, we used to rarely reach for it as a standard treatment in pediatric patients with neurogenic bladder. However, as most of these patients already tolerate clean intermittent catheterization, it has become our practice to offer a trial of awake injection. In our initial experience of awake injection in the operating room, awake injection was offered to 22 patients. 18 of them, 4 to 20 years old, elected to proceed. All 18 were managed with CIC at baseline. 14 had anxiety or behavioral issues. 10 had cognitive delay. Only 2 patients required conversion to general anesthesia, and one of these patients subsequently opted for a repeat injection trial awake. 15 patients had or planned subsequent awake injections. Of the remaining, 1 progressed to needing a bladder augment, 1 is considering an ileovesicostomy, and 1 requested subsequent injections under anesthesia. There were no intraoperative complications. Since then, we have successfully performed a number of awake injection procedures in clinic in children as young as age 2, with a significant savings in per encounter charges and OR resources. With Natalia, we're now prospectively studying the experience of our patients and families with awake Botox injection, including a plan for a clinical trial to determine the benefit, if any, to a pre-procedural lidocaine bladder soak, which has not yet been well studied in pediatric patients. In another project that has a lot of personal meaning for me, I've been working with Dr. Hansen studying the caregiver experience in our pediatric and adult transitional urology population in collaboration with Dr. Kopp and Dr. Susskind. There's been a lot of interesting work published on caregiver burnout for the aging population with dementia, but much less so in our own urology populations. In a 2018 Facebook-based survey of over 400 caregivers of patients with spina bifida, Dr. Hansen's team found that nearly 30% of caregivers surveyed were at risk of burnout based on a validated standardized questionnaire, and that this increases with caregiver age and the number of caregiving tasks reported. Based on this, we went on to design a study specifically around the complex congenital urology population with lifelong care needs here at UCSF. We created a caregiver database linked to a transitional urology patient registry that includes patients in both our pediatric spina bifida clinic and our adult transitional urology clinic. We've built a longitudinal automated personalized web-based survey that, in addition to detailed caregiver demographics, also collects information on patient needs and degree of dependence on caregivers for daily tasks. At each annual survey, we collected validated measures of caregiver anxiety, depression, and burnout. We've also incorporated validated adaptive measures of social support in multiple domains to assess its ability to ameliorate burnout. And as our patient and caregiving populations age, we've included questions about planning for the future and both virtual and physical validated measures of caregiver frailty. In our pilot with 12 caregivers aged 15 to 60, we've had excellent retention rates and completion of our longitudinal surveys over the course of a year, and we're now beginning to recruit participants in earnest. And finally, coming back around to this idea of bedside to bench and back. After a long day in the OR at Parnassus a couple years ago, Dr. Stoller and I were sitting in the command center griping about how tired we were of sending stone patients to the ICU, regardless of how many antibiotic courses they had received preoperatively. We decided it was time to find an alternative. Dr. Stoller had been musing on the possibility of a mechanical antibiotic alternative that could trap and remove bacteria from the urinary tract, and so we set out to try and make one. In addition to being effective, our device would need to be biocompatible and scalably manufacturable. In looking for technical advisors with expertise in biomedical device design, we were introduced to Dr. Kaushik Chowdhury at the Indian Institute of Science in my hometown of Bangalore, a materials engineer who's done some very interesting work in creating bactericidal nano and microscale etch topographies that have been applied to the surfaces of orthopedic implants in order to help the hardware resist biofilm formation. Late night international brainstorming sessions by Zoom got everyone excited about the possibilities, and we established a collaboration. This past year, we have started working on a grant application and jointly hired a postdoc to Deepak Patel, who's currently fabricating and testing device prototypes for us. We're in the process of filing a joint provisional patent, so I unfortunately can't discuss our technical approach in detail today, but we have some promising preliminary data showing the ability of our prototypes to clear bacteria from culture solution. It's obviously a high-risk project, and we will likely hit some roadblocks, but even on the slim possibility of pulling this off, the impact would be profound. In addition to reducing antibiotic overuse in the growing nursing home population with recurrent UTIs, there's application to stone patients and to our congenital urology population at risk for urinary tract colonization due to catheterization and stasis from obstruction. I am very grateful to Dr. Stoller for encouraging me to dream big and for showing me that I don't have to wait to be done with training in order to start reaching for the possibilities. In addition to those already mentioned, I'd like to thank all the other people in the department that I've had the chance to learn from and collaborate on research projects with over the last 6 years. I am truly grateful for the opportunities and excited for the possibilities ahead. Thank you.
It looks like we have time for 1 or 2 questions here for Maya. Does anybody have any questions here? Happy to put it on the chat. Well, I think we'll just proceed with the format, and then we could ask some questions a little later. But sounds like it was a productive year for you, Maya, and we're looking forward to hearing your advances when you go to CHOP next year in Philadelphia, where it sounds like you'll have to be wearing a mask. So next up is Heiko Yang. Heiko has had a very productive year. We're looking forward to hearing his talk.
Great. Thank you so much, Dr. Stoller. Good morning, everyone. Really appreciate this opportunity to talk about my research. As some of you may know, I was involved in several basic science projects during my research year. And the one common theme was the use of single-cell RNA sequencing to learn about different disease processes. So today, I wanted to share my experience with single-cell technology. So as the name suggests, the goal of single-cell RNA sequencing is to catalog every gene that is being expressed in every individual cell within a tissue. The way it works is you dissociate any tissue of interest into single cells, and then using some really clever biochemistry and advances in computing, you can sequence and analyze each individual cell's mRNA. It's a really simple concept, and it's an incredibly powerful technology that allows us to characterize cellular behaviors and interactions with an unprecedented precision. So you can study how similar cell types within a tissue might actually be expressing different genes, or you could study changes in gene expression of different cell types over time without losing track of their identities. And just as an example of how it's being used in cancer, this is a paper published by our group earlier this year that describes a novel androgen-responsive cancer cell type called the club cell in prostate cancer using single-cell analysis. And just to orient you, if you're looking at single-cell data for the first time, this plot right here, it's called a UMAP, and it's just basically it's a spatial representation of all the cells that are being analyzed. Each individual dot represents a single cell and all of its transcripts. The cells that are more similar cluster closer together, whereas cells that are different cluster farther apart. So during my research year, I learned how to do single-cell RNA sequencing and applied it to 2 disease processes that I find very interesting. First one is bladder cancer. You can see here, this is a giant bladder tumor in a specimen after a cystectomy. And here you can see a kidney that's, as Dr. Stoller likes to say, chock full of stones right here. This was one of our nephrectomies from the county this year. So for bladder cancer, I was specifically interested in learning more about the biology of histologic variants. Variants, as most of you know, are clinically aggressive cancers that have a very unpredictable response to treatment. Because of their relative rarity, variants have been very difficult to study, mostly because we just don't have the data on a molecular level. So using the single cell approach, I wanted to see how does the histology, so how does the appearance of the variants, how does that actually correlate with their biology and also wanted to see if we could potentially identify genes or cellular processes that we could potentially exploit to improve our ability to diagnose and treat these cancers. So the approach to this project was conceptually very simple. We took a bunch of histologic variants. We did single cell sequencing on them. We then took a bunch of pure urothelial tumors, and we also did single cell sequencing. And the goal was just to compare and contrast the biology of these different tumor types based on the single cell expression data. So to do this, we collected a number of tumors from both cystectomies and TURBTs over at Mission Bay. We took the tissue, we processed it using a bead-based single cell platform called Sequel. I'm not going to go too much into detail about each of these steps. Just know that it's a lot of pipetting, and each run through for this took about a month to finish. I listened to a lot of podcasts last year. As a result of all this, we analyzed tumor cells from 10 histologic variants, 4 pure urothelial tumors, and 1 non-urothelial bladder tumor here, the paraganglioma. And as a validating cohort, we also analyzed 8 high-grade urothelial carcinomas from an existing single-cell data set. And this is the UMAP that we generated. And the first thing that we did was we ID'd the tumor cells and separated them from the benign cells of the tumor microenvironment shown here. And how did we know that these were tumor cells? Well, 2 ways. One, we used canonical genes or urothelial markers like EpCAM or KRT7 to identify these tumor cells. And we also looked at the chromosomal copy number variation after we had separated these cells out to see that, yes, indeed, the cancer cells have much more high variance in the copy number variation due to their biological derangements. So we extracted the tumor cells and we generated a new UMAP, and the picture then becomes a little clearer. On the left, the clusters are color-coded by each individual tumor, and on the right, they're color-coded by histology. And I want to highlight that the variants are in blue and the pure urothelial tumors are in green. So what immediately jumped out to us is that none of the tumors, even those with similar histologies, actually share much overlap from a clustering standpoint. And you can see here, these are 2 nested tumors that are very far apart from each other, just spatially, 3 micropapillary tumors, also clustering separately. And we also wanted to see, okay, well, it's nice that we can see that on the UMAP projection, but how do their biological pathways actually compare? So we performed a gene set enrichment analysis of the 3 micropapillary tumors, and we found, as you can see, very few similarities in oncogenic pathways, which are shown above in the top row, and the basic biological processes here in the bottom row. So this was kind of an emperor has no clothes moment for us, because we just really had to start getting used to the idea that histologic appearance or categorization may not correlate well with the biology of these tumors. So we decided to be direct, and we wanted to ask, what genes do these variants share that the pure urothelial tumors don't? So we performed a volcano plot of all the different differentially expressed genes and all the variants and lumped together, and the pure urothelial tumors also lumped together over here. So all the genes to the left are more likely to be expressed or more expressed by the pure urothelial tumors, and all the genes to the right are preferentially expressed by the variants. And interestingly, our top hit for the variants was a gene called TM4SF1. Probably no one has heard of that, but we got very excited about this. TM4SF1 has been previously described as a gene that mediates cancer invasion, seen here in a scientific reports paper in 2017, mediating what's called an invadapodia, a structure in cancer cells that allows them to degrade their extracellular matrix around them. It's also been in several other studies proposed to be a part of the epithelial mesenchymal transition process. When we looked at TM4SF1 through the TCGA database using bulk RNA-seq data, we saw that, yeah, it actually does correlate with very aggressive tumor biology. So number one, you can see here that TM4SF1 is only expressed or only highly expressed in high-grade tumors. It's not too surprising. And the expression levels do increase by stage of bladder cancer. And then if you look at the Kaplan-Meier curves of the TM4SF1 expression, for TM4SF1 high tumors in urothelial, renal cell cancer, and pancreatic cancer, this is a very poor prognostic indicator. So this is a really exciting gene that we found. And our question was, how did we not see this in the bulk RNA sequencing data before? So we just did it ourselves. We looked at TM4SF1. We categorized using the COBRA database in conjunction with the TCGA sequencing data. We looked at variants versus pure urothelial carcinomas, looked at the expression levels of TM4SF1, and we saw no difference. So how could that be? Well, it turns out that when you use bulk RNA sequencing data, you get a lot of contamination from surrounding tissues, but specifically endothelium, where it's previously been described to be expressed. Endothelial cells, which highly populated in bladder tumors, can really skew the magnitude of TM4SF1 expression. So we decided we validated our finding using staining in both the primary tumors and the nodal tissues of the variants and the pure urothelials. And we did see, concordant with our single cell results, that in variant tumors, you have a high level of TM4SF1 staining, and the pure urothelial, you have a low level. And interestingly, there seems to be a high level in the nodal tissue as well. And I think this is a very interesting finding that we're going to spend a little bit more time investigating as the next steps. So what are the future directions? Well, now that we've found this target, we do know that there is an anti-TM4SF1 antibody that's conjugated with a drug that has been shown in several in vitro models to have anti-tumor activity. And fortunately, during this year, we were also able to develop an in vitro organoid culture system that allows us to test drugs on tumor cells that were derived from patients. So this is an example of a drug curve using standard chemo, using immunotherapy, and seeing how it kills in these 3D culture systems. So the next step would be to test that TM4SF1 antibody. So for the last few minutes, I wanted to talk about using single cell technology to learn more about kidney stone disease. So with kidney stone disease, one of the underpinnings of how kidney stones form is the idea of the Randall's plaque hypothesis. Randall's plaque, as many of us know, are these subepithelial deposits of calcium phosphate that then go on to nucleate calcium oxalate stones. Based on my work in Sunita's lab for the last year, we have very good reason to suspect that there is a cellular process involved in Randall's plaque formation, specifically an inflammatory process that involves macrophages seen here. This is an immunofluorescent microscope image showing we have pro-inflammatory macrophage markers, anti-inflammatory macrophage markers, and we see that these are aggregated next to a Randall's plaque. So we took a bunch of kidney specimens and we did single cell analysis. Here, just the three major categories that we looked at were Randall's plaques themselves. We did stone former renal papillas, and we also did non-stone former renal papillas. And we generated some really fascinating UMAPs. I'm not going to go into too much detail, but you can already start to see differences in the clustering and the expression of these different cell types. And very promisingly, one thing that we did find was that when we looked at just the macrophages and the vascular endothelial cells from the single cell data set, we see that there is a cluster of both types of cells, macrophages and vascular endothelial cells, that are specific to the Randall's plaque, shown in blue. For the macrophages, this specific cluster is very highly enriched in a gene called osteopontin. And in the vascular endothelial cells, it's highly enriched in a gene called E-selectin. And if you look at the vascular endothelium to macrophage interactions, so using this algorithm that predicts gene interactions between different cell types, we see basically a 10-fold increase in the number of vascular endothelium to macrophage interactions, just purely looking at the number of interactions, suggesting that there is a crosstalk between vascular endothelial cells in the Randall's plaques and the macrophages. And where does osteopontin and E-selectin come in? Well, both of these genes have been previously described in both kidney stone disease and atherosclerosis to be important for biomineralization. So this is super exciting. This is just the tip of the iceberg. We still have to take a really deep dive into this single cell data set, but I'm really, really excited to continue this work. So the next steps, one of the really cool things that we also did throughout this year was we developed some in vitro assays and advanced imaging techniques to really study functionally how macrophages and biominerals interact in culture. So on the left, you can see here, this is a culture of macrophages that were actually derived from patients with kidney stones. And we're looking at what happens to the macrophages if you add calcium phosphate particles. And then on the right, you can see these are electron microscope images where we can not only have just the electron microscope image of the macrophage and some calcium phosphate particles, we can use advanced imaging techniques to actually see what the composition is. So this is a calcium, phosphorus, and carbon. And you can see if you want to really detect a biomineral that may even be inside the cell, you can detect that calcium phosphate deposit. So super exciting. I just wanted to finish my talk here and just say that, I hope, the take-home message that you've gotten from this talk is that single-cell analysis can be a super powerful tool in both oncologic and non-oncologic urology. We found using single-cell that we could not find in bulk RNA data that TM4 SF1 is a novel marker for histologic variant bladder cancers. And we already know that it has a lot of clinical correlations with poor prognosis. And we're excited to see where that takes us in terms of a diagnostic or therapeutic standpoint. And then secondly, there is using single cell to look at specifically, you can zero in on specific cell types like macrophages and vascular endothelial cells. You can detect parallel biology between Randall's plaques and atherosclerosis. Finally, again, functional testing of these findings, it's the key to validating the biology, and I'm excited to move forward with both these projects to see where it takes us. Okay, I wanted to thank my mentors, Dr. Porton, Dr. Huang, with the bladder cancer project. Dr. Huang in particular, I was in his lab and he really taught me how to look at the single cell data, to analyze it, and gave me a lot of resources to do all of these experiments. Obviously, Dr. Stoller, Dr. Ho, Dr. Chi have been fantastic mentors on the kidney stone side of things, giving me the support to collect all these specimens, to really think about how to, what sort of hypotheses we wanted to generate about these stones. And I feel very fortunate to have the opportunity to stay at UCSF to do my fellowship here in endourology. Also want to acknowledge just all the amazing people that I've had the fortune to work with over the last few years from a research standpoint. And I wanted to give a specific shout out here to Han Bing. He's the postdoc in Franklin's lab, who really basically taught me how to, number one, taught me how to do the programming, and has helped me with a lot of the analysis for the single cell data. I want to thank my co-chiefs. Yep, that concludes the talk, and hopefully we have a little bit of time for questions.
Well, I want to thank all three of you. It sounds like they were incredibly productive and insightful years, and hopefully will be the template by which you could move forward with all of your careers. When I think about my career, early on when I was at your stage of the game, nothing that we're doing now even resembles what it is. And so I'm hoping a couple decades forward that you'll be able to take all these projects and move them forward. Couple of comments here. Ben Breyer says, terrific job to everyone. We're all proud of you. And I think that echoes most of us here. Alan Schindel says, John, what will happen with your pelvic organ prolapse project? It seems like a big win for women. Would hate to see it disappear. So how are you going to continue with these projects, John? You spent a tremendous amount of time identifying the problem and coming up with a potential solution. How are you going to continue with these, not let them become stale?
Yeah, so definitely the pelvic organ prolapse project, we'd love to see that continue. It's not necessarily aligned with my focus, but we gathered a lot of data that should be carried forward. For the ICI project, though, I would like to pick that back up. I think there is a viable model for that one, just potentially like pairing with Pfizer that has Cabroject. We spoke with them, or some of the other kind of novel ED companies like HIMSS. So I'll definitely plan to keep that one alive.
If you were to give anybody advice about how to identify clinical problems, what would you say would be your advice to folks?
Start with the patients. I think that's where we got our biggest insights. The POP problem, I had no idea prior to this year how big it is, even though I've been dealing with those patients clinically. But based on the market research, the number of responses that we got versus like ED, for instance, like, were just overwhelming. So it's very clear that there's a need there for more solutions.
Dr. Overland, how are you going to continue your projects over at Children's Hospital of Philadelphia? Any thoughts about how you'll continue your variety of projects?
Well, Dr. Shilley, that's an excellent question. As you and I have discussed, we're hoping that there's a lab there where we can move our device testing over and do our animal studies and continue moving forward with that project. It's been really fun to be able to set up an international collaboration. We're all kind of used to meeting by Zoom at this point, so hopefully we can be multifocal in our attack on this.
Yeah. With the UTI, obviously there's applications in the pediatric and adult populations, which would be great.
Absolutely. The CHOP team's really excited about what it could do for our spina bifida populations and general urology patients in general.
And Dr. Yang, what are your thoughts about where potentially translational implications could be for your findings?
Well, hopefully on the bladder cancer side of things, hopefully this TM4SF1 marker bears out to be something that we can actually use to target histologic variants. Like I said, there is an antibody. Someone made an antibody that's conjugated to a drug that can kill these cells. So if we do see that there is activity, I think that would be very significant for these bladder cancer patients. And then from a kidney stone standpoint, I mean, I think my big thing has always been, we're so focused on the urinary space of kidney stone formation, with the 24-hour urines, with the chemistries and things like, on that side of things. I think understanding the cellular mechanisms that are inside the kidney that are happening to nucleate to start the kidney stone formation, I think understanding that and being able to treat that process would help us significantly in preventing and treating stone disease.
Well, on behalf of the whole department, we're all very proud of you guys, and we're looking forward to seeing how all of your careers blossom and continue to grow. So it's a little after 8 o'clock. Let's go to it for the day. And thanks to everybody for attending. Bye-bye.